My name is Paul Foley. I'm a vascular surgeon at Doylestown Hospital in Doylestown, Pennsylvania. I'm based out of Doylestown Hospital, which is a suburb of Philadelphia. I do a wide range of vascular surgery, open and endovascular. During training as a vascular surgery fellow, the interventional cardiologists and cardiac surgeons began using shockwave for vessel preparation to deliver aortic valves. So I had heard about shockwave and the technology surrounding it with respect to vessel preparation, but never utilized it for any peripheral intervention. In my practice, I have struggled with endovascular intervention for heavily calcified lesions ever since I've been in practice, achieving a suboptimal result with balloon angioplasty alone, struggling with the balance between using larger size balloons or higher atmosphere pressure to achieve a luminal gain response, balancing that against damaging the vessel. So several years ago, I began using intravascular lithotripsy as a way to modify calcium to achieve a greater effect with my endovascular intervention, specifically in the lower extremity. I first began using it with calcified lesions in the SFA POP distribution for really bulky calcified disease where I knew from past experience I was not likely to achieve a good response with balloon angioplasty and stenting by itself. And very quickly became very pleased with the results I was achieving with calcium modification and vessel preparation prior to additional endovascular therapy. Following that, I began to incorporate it more into my practice for below the knee space. And certainly I've used it quite a bit for calcium modification in an effort to achieve device delivery for aortoiliac interventions and aneurysmal intervention for endovascular aortic therapy. The imaging modality that I feel most comfortable with and utilizing for vessel diameter measurement and sizing of intravascular lithotripsy is CT angiogram. I utilize it very frequently preoperatively for lower extremity and aortoiliac interventions. To me, I can achieve accurate sizing diameters from cross-sectional imaging in the iliacs, common femoral, superficial femoral artery, popliteal artery. Based off of the diameter measurement I get from the CT angiogram, I will then oversize by 10% to achieve the desired diameter for the shockwave balloon. When I first started using intravascular lithotripsy, I saw it simply as another balloon intervention without really understanding how impactful it could be to modify the calcium. So I was nervous simply because of our background and training in not wanting to be too aggressive with endovascular intervention at larger balloon sizes or with higher atmosphere pressure and risk damaging the vessel and leading to dissection or thrombosis or extravasation. Then you're committed to an additional intervention that you may not have wanted to do. So being apprehensive early on in my adopting the technology, I would simply see this as another balloon modality. As I utilized it more and more and really started to understand the technology and how it could be utilized for successful vessel preparation and calcium modification, I started to see it differently and started to view the balloon not so much as a balloon, but more as a vehicle to fill the space and achieve the interface between the flow lumen and the calcium so that you can get very effective energy delivery into the calcium for more effective modification. So when I started becoming comfortable with that approach, I really became more comfortable with the more aggressive sizing strategies for certain vessel beds, So now when I size, I'll utilize the available imaging that I have to appropriately choose the diameter of the shockwave balloon catheter. So for example, for aortoiliac interventions or iliac interventions, I would base the sizing off of an existing CT angiogram. I've been in many cases where historically I would balloon angioplasty something and know upfront that I was going to be underwhelmed with the effect of balloon angioplasty alone, simply moving calcium to the side only to have a recoil stenosis or to achieve minimal luminal gain, if anything, on subsequent arteriogram. What I've been most impressed by is the ability to achieve significant improvement in lumen size, achieve significant luminal gain, and then be in a position where I'm looking at a subsequent arteriogram and not knowing how I should proceed and whether or not I really need to stent that or not because I'm so impressed with the final result. I've been particularly impressed with the improvement in vessel lumen and achieving a result at spots where historically I would not want to stent, specifically in the common femoral artery and in the popliteal artery. But there's been many times where following intravascular lithotripsy, I can now look at the flow through a treated segment and be very clear that that doesn't need to be stented and can get away without leaving hardware behind. My tips for sizing have to do with ensuring that you oversize by 10%, because I really believe in ensuring that you fill the space within the lumen where you're treating the calcified disease to achieve adequate energy delivery into the plaque. If you undersize and there's inadequate contact or inadequate interface between the balloon and the plaque, you won't achieve adequate energy delivery and you're not accomplishing anything. So utilizing the available imaging and sizing appropriately, increasing by 10%, is really important in my mind to achieve the desired clinical result. So we'll run through some cases to highlight the applicability of intravascular lithotripsy in endovascular intervention. First patient is a 63-year-old male who has past medical history notable for hypertension, hyperlipidemia, significant smoking history, and presented to the office with debilitating bilateral lower extremity exertional pain, specifically located in his thighs and calves. His preoperative non-invasive vascular studies were abnormal bilaterally with reduced ABIs on both sides. His physical exam was notable for weak femoral pulses and non-palpable pedal pulses. So in this specific clinical scenario, I would achieve a CT angiogram of the abdomen and pelvis as well as a lower extremity runoff, expecting to find multi-level disease, but specifically looking at the aortoiliac segment in this specific patient. So a preoperative CT angiogram was obtained, as you can see here, which demonstrated significant calcified plaque in the bilateral iliac arteries, heavy, bulky luminal plaque contributing to bilateral significant iliac stenoses was demonstrated on the CT angiogram. Very easy to achieve cross-sectional diameter measurements, as you can see here, with diameter measurements of approximately 11 millimeters bilaterally. Centerline reconstruction of the CT angiogram clearly demonstrates bilateral iliac occlusive disease with heavily calcified plaque and high-grade stenoses. There's some post-stenotic dilatation evident in the left common iliac artery. So he was brought to the operating room for endovascular intervention with a plan to treat his common iliac artery disease with intravascular lithotripsy. Bilateral femoral access was achieved. We did achieve retrograde crossing of the iliac lesions quite easily bilaterally. Again, the size of the shockwave balloon was determined based off the pre-op CT angiogram measurements. If you recall, the common iliac artery diameters were 11 millimeters bilaterally. Therefore, I chose a 10% oversizing, which would lead us to the 12 millimeter L6 catheter. So the L6 balloons were inserted over the wires bilaterally and positioned in the desired locations. Intravascular pulse delivery was achieved at subnominal pressure across the calcified lesions, followed by balloon angioplasty. Multiple rounds were delivered into the calcified stenoses bilaterally, and all 300 pulses from each catheter were delivered. This is an example of one of the inflations with the image seen here. Following the intravascular lithotripsy pulse delivery, we achieved really an excellent technical result, but in my practice in general, I do like to treat iliac occlusive disease with covered stents. Therefore, the completion was with bilateral 10 millimeter Gore VBX balloon mounted stents, which were then positioned in the desired location, deployed, and posted to 12 millimeters bilaterally. You can see here on the left of the screen, this was our completion result after simply intravascular lithotripsy bilaterally alone, which is really an outstanding radiographic result. This was one of these times where I look at an image and I say, should I stent this or should I not stent this? But routinely in my practice with iliac occlusive disease, my preference is to stent the iliac disease following vessel preparation and endovascular intervention. So the completion result on the right of the screen was after placement of the 10 millimeter bilateral Gore VBX stents and post-dilated to 12 millimeters, and we achieved really an outstanding technical result. Follow-up with him in the office after an uneventful post-op course was that he had complete resolution of his lower extremity symptoms, walking an unlimited distance with complete normalization of his ABIs bilaterally, and his postoperative aortoiliac duplex demonstrated widely patent iliac stents bilaterally. So really an excellent technical result. The second case, moving further down the leg, to show you a intervention in the superficial femoral artery and popliteal artery space. This is a gentleman who presented to the office with past medical history, similarly of hypertension, hypercholesterolemia, and former smoker. He had significant coronary artery disease and had had a previous left common femoral endarterectomy several years ago. His presenting symptom was debilitating left lower extremity claudication, and his preoperative lower extremity arterial duplex demonstrated a very heavily calcified lesion in the left popliteal artery with elevated peak systolic velocity and a elevated ratio of 7, consistent with a significant stenosis at this location. So he was brought to the operating room for a diagnostic arteriogram and potential endovascular intervention. As you can see, starting from left to right, his popliteal artery demonstrated significant bulky luminal calcified plaque consistent with his preoperative duplex. We were able to cross the lesion, and as you can see on the next picture, I put a balloon angioplasty across performed balloon angioplasty across the calcified lesion with a 4 millimeter balloon, which is traditionally what I would use to treat a smaller diameter popliteal artery below the knee or behind the knee. But it was clear that this was undersized for the diameter of the vessel. So I decided to proceed with a 6 millimeter M5 shockwave balloon to treat the calcified disease behind the knee. I was able to easily advance the catheter across the popliteal artery disease, and alternating rounds of pulse delivery at subnominal pressure followed by angioplasty with the M5 balloon were performed across the entire segment of calcified disease behind the knee. And the completion result, as you can see on the right, shows a widely patent popliteal artery with no significant residual stenosis and brisk flow. This is one of the cases where historically I'd be somewhat apprehensive about stenting behind the knee, but I was able to achieve really an outstanding technical result with intravascular lithotripsy alone and did not have to leave any stent hardware behind. The patient's postoperative course was uneventful. He had immediate symptom resolution, had on follow-up a normal ABI and a normal TBI, and at 8 months follow-up, his arterial duplex continues to demonstrate a widely patent left popliteal artery with no velocity evidence for residual or significant stenosis. And he remains symptom-free in follow-up 8 months post-procedure. So really a very nice radiographic, but also a outstanding clinical result. The last case I'd like to present is a below-the-knee case for a patient with critical limb-threatening ischemia. This is where I believe intravascular lithotripsy has potentially the most benefit and fills a treatment void that exists right now. And this is the space that I believe I'm most excited about. So this is a patient who came in, typical arterial disease risk factors of hypertension, hyperlipidemia, diabetes, and coronary artery disease. The patient had critical limb-threatening ischemia, which was manifested by a left fourth toe infection with underlying osteomyelitis. Preoperative vascular studies were abnormal, demonstrating an unmeasurable ABI consistent with heavily calcified arteries and non-compressibility, and a reduced TBI as well, as you can see here. The patient was taken to the operating room, which demonstrated extensive tibial artery disease, which was heavily calcified, which I'll demonstrate here. So the patient had a mid anterior tibial artery stenosis and in the proximal segment, and in the mid segment of the anterior tibial artery there was a calcified occlusion. I was able to get across the anterior tibial artery disease and performed a balloon angioplasty with a 2 millimeter balloon, achieving a suboptimal result. There was significant recoil stenosis in the area of calcification and did not achieve the luminal gain I was hoping for. This is one of these situations where historically you have a decision to make and balance between a larger balloon or higher atmosphere intervention, which could potentially damage the vessel, cause a dissection, or lead to tibial artery thrombosis. So in this setting, in order to achieve a better luminal response and modify the calcium, I elected to proceed with intravascular lithotripsy. So after intervening with a 2 millimeter balloon, which was clearly a suboptimal diameter and undersized for the luminal gain I wanted to achieve, I then intervened on the anterior tibial artery disease with a 3 millimeter S4 shockwave balloon. All segments of anterior tibial disease were treated with pulse delivery at subnominal pressure and balloon angioplasty at nominal pressure, pulling back across the entire segment of anterior tibial disease from the mid to distal segment to the proximal segment. And what you can see here is a really dramatic improvement in the lumen of the anterior tibial artery, both at the proximal stenosis and the mid-segment occlusion. And the completion result achieved a very nice radiographic response with brisk flow through the anterior tibial artery and no significant residual stenosis, with flow into the dorsal pedal artery and out into the forefoot. So this really highlights an example of limitations of traditional balloon angioplasty in the below knee space and the type of result that can be achieved with intravascular lithotripsy and calcium modification, which I really believe is an existing treatment gap that can be filled with vessel prep and calcium modification that can be achieved by the shockwave balloon. Patient had an uneventful postoperative course. The patient went on to have a toe amputation with closure, and the wound healed without any problem. Her post-procedure TBI improved significantly from 0.41 preoperatively up to 0.65, and she achieved a nice clinical response. So a very nice radiographic and clinical response in this scenario.